good morning everybody. Thank you for giving up your Saturday morning, and thank you very much for inviting me to speak. I appreciate the opportunity. I absolutely love what I do, and I hope everyone in the room also loves what they do, because it truly does take a village, and it takes all of us to be at our very best, to think differently and to approach things with an open mind and an all-encompassing don't get too blinkered in what you're doing, is what I'm basically trying to say, because there are so many different facets to everything we do. I really feel that we've become far too modern for our own good. If you think about nature and physiology, our physiology developed a very, very long time ago when conditions were very different to how they are today. But we've become very modern, and our physiology hasn't quite kept up with the things that we're doing now. We've changed the purpose of our mouth, our nose, and how we function with it. And that's profoundly changed the way that our craniofacial development has occurred. So I believe that we need to respect nature. One of the things I love about CPAP machines is that they actually are very respective of nature. And what do I mean by that? It seems very odd to have some sort of contraption on your face and blowing air, etc. But the reality is, what it's doing is stenting open the airway so that you continue to breathe by yourself. It's not ventilating you, it's not doing all of those things. When I explain it to patients, I'll often say that, you know, it's like one of those things at the football where they score the tries and they have those blow-up machines and it's just blowing that air in there, but you continue to breathe yourself. So from that, it's not a drug, you know, it's actually very supportive of nature, because nature wants us to have an airway. It's a pretty important concept. We can't beat nature either, okay? How we turn out is our physiology. It is our physiological response to the function that's happening. It's not just the genes. In fact, we turn out in many cases a long way away from what our genetic template was in the first place. But we, as practitioners, can create an environment that enables nature to do its work. Just like the CPAP machine, just like in a dental field, we can support the structure of the jaw to actually put it in a position to allow a lip seal. Because if you've got a child who's got a 12mm overjet and you're asking them to put their lips together, breathe through their nose, put their tongue on their palate, you're going to be tearing your hair out and they're going to be frustrated, and it's going to be a nightmare because the structure is not supporting that function. The structure has grown in response to the aberrant function that was occurring. Okay, that's how it developed like that. But then that structure supports that bad function, and it becomes a very vicious cycle. So if we want to correct the function, we have to think about the structure. You can't think of them in isolation. So my functional therapist can't work in isolation from practitioners who do jaw development, and jaw development practitioners cannot work in isolation without addressing the function, because you can move things, you can put braces on things, you can move teeth, you can do all sorts of things, but unless the function changes, you're either going to have a less than great result, or you're not going to get the result, it's going to be a slow result, or you're going to have relapse. Because I'm telling you, nature will win every single time. The function is going to win. That's the more powerful of it. So the function has to change. The role that you play is incredibly important, and it's equal. An orthodontist in America pulled me aside one day because he was having difficulties with the concepts that were being discussed in the lecture about facial growth, airways and breathing. So I sat down with him, and through my lecture, it was on the development of sleep apnea in children. And through that lecture, I just did it one-on-one with him, and he tapped me on the shoulder halfway through it, and he said, so Anne-Maree, what you're saying is If they're not breathing right, they're not growing right. And I went, yes, yes. I still, whenever I say that now, I still get goosebumps. He got it. And he, from that moment on, had a whole different concept as to what he was doing as an orthodontist, what he was looking for. Nature gets it right. And isn't everything in nature beautiful? Even the scariest looking creatures, they're beautiful. So why, as a race of, or what I don't know what to call us, as human beings, why are so many of us so plain? Why are we not stunningly beautiful? Because everything else in nature is. So when you see that person who is stunningly beautiful and you cannot take your eyes off them, I promise you, you won't notice their jaw, but they will have a beautiful jaw that's grown out from under the cranium. The upper jaw will be out where it belongs, the lower jaw will be out where it belongs, and they will look perfect. Because that's how nature did intend them to be. And it goes awry, not because of the genes, but because of the function that happens after we're born. Something that is prevalent does not make it normal. And unfortunately today, we have a huge prevalence of malocclusion. Everybody needs braces. You know, it's almost an expectation, when is my kid going to get braces? Well, guess what? That's actually not normal, just because it's prevalent. There's always been a 5% malocclusion rate. So 5% of people through time, there's been a malocclusion. A lot of that's due to pathology, accidents, you know, things going wrong genetically. So not everyone has been perfect forever. But until 10,000 BC, it was a 5% malocclusion rate. Around 10,000 BC, the hunters and gatherers became farmers, and our diet changed as a result of that. And there was an increase in that time of malocclusion. But it's gone very awry since industrialisation and urbanisation has occurred. Today, we're looking at 95% malocclusions. If you really, not everyone runs off who's got a malocclusion runs off to the orthodontist, okay? But 95% of the time, you don't get that perfect jaw. You don't get perfect jaw development, you don't get perfect jaw size, you don't get room for all the teeth. See, the teeth are perfect. The teeth in both of these jaws are absolutely perfect. And it looks like on the left that that jaw is sitting further forward than the one beside it. You can see how narrow and triangular the shape is. The teeth are perfect. They've just gone for a ride. They're just trying to fit inside the incorrect size, shape, and position of the jaws. So why do we look at teeth when it's not the teeth that are wrong? They've just gone for a ride. It's the jaw size, shape, and position. This jaw here, that jaw on the right, which is a more normal, which is rare to see, but a more normal shaped jaw, that is further forward in that person's face than this one is in this person's face. Yet this one looks like they've got buck teeth. Why do they look like they've got buck teeth? Because the mandible, which gets wider as it goes back, is trying to fit inside this narrow triangular shaped jaw, and the only place it fits is more up like this. And what's that doing to the airway? Okay. What's it doing to the muscles? You think about having a child on a swing and you're playing with them and then you hold them like this. And that's fun for about a minute until your muscles get tired. Every one of you, if I said go tap, tap, tap on your back teeth, you'll go straight to that spot. And the only reason you go there is that that's where they fit together. That's it. That's where it fits. So this upper jaw didn't develop in its size, shape and position. It didn't grow out from under the cranium. It stayed back, it stayed narrow because there was mouth breathing and there was a low tongue posture and there was a tongue thrust and there was no lip seal. So these things were all going wrong and the mandible's adapting to stay in occlusion, and it's gone back and back. And all of a sudden, it looks like there's buck teeth. But it isn't. It's an optical illusion. You bring that jaw forward, lines up beautifully. And we can put this jaw anywhere. You don't think you can, but you can. But we need to put it where it belongs. We need to put it right if we're going to change something. So what brought about all of this change? Well, certainly there was dietary changes, okay? Our ancestral diet was a lot tougher, more fibrous. There are very important principles of bone growth, and this is an axiom of all hard tissue biology, that the more force, the more stress, the more the bone will grow. We've all seen clenches, huge amounts of bone. Bruxism, clenching, and you get buttressing bone, you get tori, you get antegrade, you get huge changes in the bone. So this concept is universally accepted amongst scientists, but the low mechanical property of food does not elicit the mechanical forces needed to make it grow. So you not only need the big three, nasal breathing, lip seal, good tongue rest and function, you need to be chewing hard fibrous food. You need to be chewing tougher food to put the force on the jaws to stimulate them to actually grow. Because all the body can do is respond. Bone is very conservative. If it doesn't see the force, it doesn't need the bone. Why does the medical profession say to people who are at risk of osteoporosis, go and lift weights? Because now you are putting more force on the bone, and that's what physiology does. All it can do is respond. You give it a message, it responds. You don't do your exercise and you don't lift your weights and you don't chew hard fibrous food, and you get very, very different pictures. People who are big chewers but only chew on one side, you'll see a very different density from one side to the other in their condyles and in their rami. Bone adapts to the amount of stress it gets, and it does exactly what you're telling it to do. So if that's a principle of bone development, then maybe in the orthodontic and orthopedic world, we can stimulate bone to grow. We can stimulate new bone to grow. Somebody say, well, how can you grow bone when you've stopped growing? But the anomaly there is that people think that growth is to do with vertical height. I grow fatter, I grow skinnier, I grow in all different directions. If I clench my bone, I'm going to grow bone. Okay, we're growing all the time. We're changing our tissue. If you walked out of here and broke your arm, would you expect it to heal? And if you do, what process has to happen? There has to be bone development going on, doesn't there? But the difference between right now and breaking the arm is that you had to have that stimulus. So if you apply an appropriate stimulus to this very changeable structure, this craniofacial structure, you can get new bone. You can help the growth of bone in children when it really is growth, and you can also remodel bone in adults. What else has gone wrong? Mouth breathing. Urbanisation has been linked very strongly with mouth breathing. Back in this is embarrassing to me, the awareness that people had in the 1800s and early 1900s about how bad mouth breathing was for facial development and airway. I'm embarrassed by it because I don't want to say it wasn't taught when I was at university, but it certainly didn't get through to me at that point in time, the importance of it. George Catlin in 1862, he wrote a book called The Breath of Life. And he noted that in industrialised cities at the time, 50% of children born would not be alive by the age of 5, and 50% of the remaining died by the age of 25. Yet he used to go out to Native American Indian communities and he would observe, they'd often have, you can see down here, he was an illustrator as well, and they had like a totem pole and they had the crania, the skulls of people who had passed away within their community. And he was actually quite taken aback that there were so few small crania. Where are the skulls of the children? And the chief of the tribe said to him, "What are you talking about?" He said, "They don't die. You have an accident and they die, but they're not dying." And that's at exactly the same time when in the cities they were dying, obviously influenza, different things that would mass kill people in that urban environment. But he did notice something quite different, and that was the amount of mouth breathing that was happening in these urban communities versus the complete lack of it in the Native American Indian communities. And he wrote in there, "It's very sad that at the very start of life they are started so wrong." And what he means by that is, when he said, "I never saw one Native American Indian woman take the child from the breast without the last thing she did was just close those lips. Just close the lips. Because mouth breathing is a learned thing. Just close the lips." And they did that every single time. And he writes in the book that it's so sad that, at the very start of life, they started so wrong in the cities because for fear of disturbing the child, they do not do this in the cities, and they don't do it from the breast or whether they would do it using the bottles. Don't know why that's not moving. William Osler in 1892 wrote the medical textbook, The Principle and Practice of Medicine, and in it he writes about the fact that the establishment of mouth breathing, this is talking about chronic tonsillar hypertrophy, the establishment of mouth breathing is the symptom which first attracts the attention. Now how sad is that? To me it's like now mouth breathing is one of the last things that attracts the attention. They were much more aware of mouth breathing in those days. And he went on to describe what this tonsillar child would be like at night. At night, the child's sleep is greatly disturbed. The respirations are loud and snorting, and there are sometimes prolonged pauses followed by deep, noisy inspirations. The child may wake up in a paroxysm of shortness of breath. Was that a description of sleep apnea in 1892? William Wells wrote about and I don't love, but it's quite amusing when you see the language, when you look at it in today's, where we are today. The stupid-looking lazy child, who frequently suffers from some headaches at school, breathes through his mouth instead of his nose, snorts and is restless at night, and wakes up with a dry mouth in the morning, is well worthy of the selected solicitous attention of the school medical officer. When I first read that, I thought they were going to say the school disciplinary officer, because often the child is also in trouble. And this one here, a degenerate who was made normal by the removal of the adenoids. So there's been dietary changes beyond moving from our hard fibrous ancestral diet as well, and that's been a movement away from breastfeeding and into artificial devices. I just think to myself, well, should we or shouldn't we? And then think back, well, what would they have done in primitive times? There was no plastic around, okay? They didn't have dummies, they didn't have bottles. Breastfeeding was the way that things were. Now, I fully understand that some people are unable to do that, but I hope that they've been checked for tongue tie and lip ties and things like that to make sure that that's all okay in the first place. But I'm more concerned with the use of dummies than I am with bottles. And the reason for that is that the dummy is in for a hell of a lot longer than the bottle is. And when you put your tongue to your palate and you suckle and do all those things, there's messaging, there's crosstalk between all the body parts. Your body parts know what's going on. You put a hunk of plastic in there, there's no crosstalk between that. You are not learning tongue to palate postures. In fact, you're learning tongue away. You're not learning a lip seal, you're learning lip apart. It's a very different messaging. And I promise you the craniofacial development is going in a very different direction because you've sent a different signal and it's not a good one. When we transition from breast milk or milk formulas onto solids, in primitive times there were no food processors. It was solids. They breastfed until the child had teeth, and then they introduced solids. And so the swallow that's required for breastfeeding is very different to the swallow that's required for proper solid food function and chewing. But if you transition from breast liquid to semi-liquid puree, the child doesn't know what to do with that. And it spits it out because it's still got the infantile swallow, and you're not making a distinctive break between liquid to solid. And that's part of the issue that happens with our continued aberrant swallows that happen throughout life. And then, of course, our highly processed foods that are part of our diet. It's become a mismatch. Our bodies were never designed to cope with this novel environment. Yet this is what our little ones are started with so commonly today. On the topic of epigenetics, Conrad Hal Waddington said, "The potential is being lost for making modification the further away from normal it becomes." So the further you send a function message that's going in a different direction to normal, and what normal genetic growth is, the harder it is to get back on track. And it's harder then for the function to support that. It gets harder for the physiology to do anything other than support the landscape that's being expressed. So that little child whose jaw's gone back like this and they've got vertically growing open bites and things like this, they're finding it hard. They can't get the lips together. They were never designed to do that. Our trigeminal system here, right here, the part that we're dealing with and talking about, the largest sensory nerve, 50% volume of all the sensory information going back to the brain. It's a proprioceptor. When you put your teeth together, the body's getting a message of where your head is in space. It's an important message. It's a protector. You think about nature, think about the animals. Sniffing, and this whole area is really, really important. We are protected by it. And it's very amenable to soft tissue change, soft tissue signalling that causes changes to the bony growth. It signifies danger and it signifies safety. It's a really important system. We also have a nasopalatine nerve, this guy here, part of that system, but that is a parasympathetic nerve. And the parasympathetic nerve, in a nice, easy way to explain it, it's all good, okay? It's the one that says it's all good, you're safe, everything is fine. And when you put your tongue to your palate and you stimulate this, that's the message that the body is getting. And when you take that tongue away, it's not getting that message. So it's a message that I'm not safe now. So tongue to palate, and not just here in the front, not just there, but the whole back of the tongue needs to be up in that palate. One of the interesting things with nasal breathing and mouth breathing, a lot of people who are mouth breathers don't like to nasally breathe, and the reason they don't like to nasally breathe is that they've got a low tongue posture. If the back of your tongue is down, when you breathe in through your nose, the little vacuum that's pulling it down here comes in and it goes into your mouth, and then it goes and it goes down, takes out all the power out of it. So these people are very shallow breathers. They're not diaphragmatic breathers. But the moment you put the tongue up in the palate where it belongs, where it entirely takes up that space, there's zero air going into the mouth. That air from the nose is drawn straight down to the diaphragm. It's a very different breathing, and if you just try that on yourselves, put your tongue right up there, take a breath, drop your tongue posture low and take a breath. It's a very different breath. That's why people don't like nasally breathing. They feel they're not getting enough air. You have to teach the back of the tongue up. Interestingly to me, I saw these skulls at a conference I was at. I had these little palette width rulers made up, and I wanted to give them to Dr. Galella. And I went to where I thought he was going to be. And Tim Bromwich, who is a biologic paleontologist, was there, and he had two skulls. He had a 2 million year old skull and a 1 million year old skull. And I've had just happened to have my palette rulers in America. I have my rulers in my pocket because I was going to give them away. And I thought, oh my gosh, I've always heard it's supposed to be 38 millimetres across from the palatal cusp of the sixes. So I got my ruler out, expecting it to be like 40 and whatever. The 2 million year old skull, 38 millimetres. The 1 million year old skull, 38 millimetres. My future son-in-law, 31 millimetres. So, what happened? What happened that in that million years, it was 38 millimetres. In the next million, it's 31, and it's not uncommon for me to see adults at 24. That's bad, but it's not uncommon. And my future son-in-law, if you happen to look a little bit further back in his mouth, had these honking big healthy golf balls in his throat, which caused him, his structure and function changed, and everything changed. So that structure then had to support the aberrant function. But those big golf balls contributed. But why were they big? Because they were doing the job of the nose. Because he was not a nasal breather. All the filtering is supposed to happen in the nose. This was his widest airway. He didn't have full-blown sleep apnea, but he was a sleepwalker. And sleepwalking is part of the arousal process that goes on. He was not only triangular to look at him from an occlusal point of view, he was triangular when you looked at him from the front, and triangular also vertically. He went down at the back. His bone, you saw the bone above his molar teeth when he smiled. Most of the time you wouldn't even see the molar teeth, or you see the cusp tips, or you saw the bone above it. That's how vertically he had grown down. When he first came on the scene, I just kept... My daughter was only 14 at the time, so I figured it was just a passing thing. But 11 years later, they did get married, and they had to do something about it. So, all the body can do is respond. Our bodies are just one big responding organ. They're responding to whatever input's coming to them. That's the job. And respond it does. So if you have a pathologic situation, like a cleft lip and palate, you're going to develop differently, but you're going to develop, if you can't maintain a lip seal, for example, you're just not going to develop the palate that you were supposed to have. And so you develop this class 3, and everyone thinks that lower jaw's bad. Oh, just look at this terrible class 3. It developed to its genetic potential, or got on the way to it. This is the one that's wrong. It's always the maxilla that's wrong. What's the response to enlarged tonsils? This is the little girl. That's her asleep, giving herself an airway. And if you look further, you can see those big tonsils. big healthy tonsils, stopping her from growing right, stopping her from functioning right. And tongue ties. Tongue ties are in adults, can have a huge impact on their temporomandibular disorder and their chronic pain and neck pain, and it's hard work. Often it's looked, oh, well, it didn't interfere with speech, or we just gave it the bottle or whatever. Well, it can be a big contributor. This patient, adult, comes to me because they've got neck pain, headaches and jaw tightness. And then how's it affecting their life? Pain, inability to focus, needing to take medication. Like, they're miserable. Now, I'm not saying that the only thing here is the tongue tie, but the tongue tie contributed to the development. Look at the crowding. The jaws have not developed to their genetic potential. It's one of the parts. It's not everything, it's one of the parts. But it's definitely contributed to the function. And what about thumb sucking? Okay? Am I allowed to say in this room what I think about thumb sucking? Yes. This will be controversial. I would rather a thumb sucker than a dummy sucker any day. And I'll tell you why. Thumb suckers get it right. They get the AP right. This maxilla is out where it belongs in an AP. It's too narrow, but I can fix that. But the AP is always right. And it looks wrong, doesn't it? It looks like they've got buck teeth. But it's purely that narrow jaw and that mandible coming back here. Don't ever allow anyone to tell you to extract those teeth and pull it back. There has to be a complete end to extraction and retraction orthodontics. Every time you retract, you diminish the airway. Everything that we should be doing is to build this face forward where it genetically and physiologically is supposed to be. The jaw needs to come forward, not back. Tongue thrust. Whenever you see gaps in teeth, between arches, in the back, in the front, if there's a gap, I promise there's a tongue thrust. Why do I promise that? Because teeth erupt till they meet their partner. When they meet their partner, they stop erupting. These teeth met their partner, the tongue. Okay, that's the partner here. Because physiology it's not in cement. It just will respond. Oh, where's my partner? Boom, bring it together. But the moment that tongue gets in there, number one, it'll force it apart further, but secondarily, it will prevent it coming together. And if you're doing any orthodontic treatment and you're just not seeming to close that bite down, the tongue, they might be doing their function right. They might be able to show you how to swallow correctly when you're testing them, but at rest, they're doing this. It's just sitting in there. And what we do at rest can be more important than what we're doing when we're functioning. What about enlarged adenoid tissue? It's quite common when you have enlarged adenoid tissue that you see this posterior cranial rotation of the head, because they're giving themselves CPR, okay, putting that head posture to create that airway. If we had corrected him to a correct head posture, this could have been closed off. So this is his posture to give himself an airway. But the problem is he grows like that then. And he will have neck problems and he'll have all sorts of problems down the track because that's how he's growing in response, because he needs an airway. He doesn't choose that. His body has said, this gives you the best airway and that's my priority. And this is right in the midline, this x-ray. There's a nasopalatal canal there. This is a tonsil that's actually crossing the midline. Because often if there's tonsils, you won't see them right in the midline. That tonsil is crossing the midline. These EMGs are measuring the muscle activity. This side here is the bite that I've taken for a sleep appliance, a mandibular advancement sleep. We then take that bite out. So this is the position the patient's going to be in at night. This muscle here is a our temporalis muscle, and it's a very fine AP positioner, anterior posterior positioner, okay? So obviously when we are taking a bite for oral appliance, we want to open that airway, so we want the jaw to come forward. But I want to know that the muscles are comfortable in that position. So I use the induce and I can see that. These muscles here represent the genioglossus area, the tongue. Now, the genioglossus is our airway protector, and it activates in obstructive sleep apnea patient, it activates day and night, but it activates all day to maintain the airway to be open. And the interesting thing here is, we take our bite out, patient then closes on their own teeth, so the bite's been here, and now they've got to bring their jaw back, and guess what happened? I'm not surprised that that happened, but immediately the genioglossus activated to keep the tongue out of the airway. All the body can do is respond, and it will respond. Everything we do to patients, as dentists, we have to be very cognizant of the fact that we do things to people. We're always doing things to people, but you have to think, is what I'm doing to you in keeping with your physiology, or am I fighting against it? And I believe we have a responsibility to have it in keeping with their physiology, because they will respond, and they'll respond in a moment, and it's not a choice. So what happens if jaws fail to develop to their genetic potential? This is really common. You end up with little tiny airways. 2.56 millimetres across, 20 across there. Square millimetres, 83. I always say to patients now, I will say this, the size of that airway is not diagnostic of sleep apnea, okay? But I do know that all these muscles here have to work a lot harder to keep that airway open than someone who's got a big airway, okay? So we don't like to see that. So I say to patients, we like to see like 10 to 11 millimetres AP, 28 to 30 laterally, area, this is in the minimal spot, 250 to 300 square millimetres across. But just as a little guide, it's not diagnostic, but it just as a little guide to me. Over here, you can see that manual. Remember I said we're holding it up like this? It's exactly what it's doing. And those muscles are holding it there. And this affects the neck. So we've got compression through the neck here. This patient will have that posterior cranial rotation, and they're compressing this region through here. They will have neck pain as a result of that. If there's not room for this because of the compression, the vertebrae then get shifted out of position as well. So this all comes down to ending up in my practice because I've got chronic pain, because muscles can't sustain those positions forever. So what happens though if it responds to, the body responds to breastfeeding, nasal breathing, lip seal and proper tongue posture? I cannot tell you how rare it is for me to see normal because of the selected group of patients that I see. But this patient came in, I think they knew I was getting ready for this lecture, flew from Adelaide to see me and came in, and I took the cone beam x-ray, and what did I say that measurement should be? 38.24. What did I say these measurements? 11.26, 32.26 and 293 square millimetres. Okay, cool, this is pretty cool. Nice straight vertebrae, things are lined up. Very, very rare for me to see. Do you remember the compression for that lady before? Okay, this is what it should look like. We need functional spaces. Look at that jaw, where's the swing here? It's not. Look where's the big bone deposition because of clenching and antigonial notching and all the other things that go awry when things don't go. This is absolutely beautiful. And what's the history? That's the history. His function allowed him to develop to his genetic potential. Look at his tongue posture. That's what I mean. It's not here. There's too much focus on tongue to spot. Whole back of tongue has to get up. It's absolutely critical. Nice wide airway. All these measurements are great. This measurement, I like it at 88. It's 87. I mean, it's amazing. Somebody saw fit to take out 2 wisdom teeth. I don't know why. But look, he's got room behind the wisdom teeth. Okay? This is what nature is supposed to be. We see it so rarely that we think prevalence is normal. Prevalence does not make it normal. So, form follows function. Look at the beautiful shape of the head of that child. He's probably never laid on his back, except maybe to go and sleep at night because he's out in the field with mum. And we lay the babies down on their back, and on their back, and on their back, and on their back, and changes. These are soft little bones. You can change anything. This is different sort of mouth breathing. But you can grow tissues. This is a rugby union referee from South Africa, one of the top leading ones in the world, good friend of ours. He likes me because he's always embarrassed with his nose. He always thinks he's got a big nose. I said, Craig, you haven't got a big nose. You've got an underdeveloped midface. Okay. So it's an optical illusion. But when he was at the World Cup in London a couple of years ago, I was over there and they were like away from their families for about 9 weeks. And I just asked him because of his jaw development. He had a jaw to one side and all these things going on. And I said, well, what about your children? Are they mouth breathers? He goes, no. And he said, well, my wife sent me a picture of him sleeping. I said, well, what about when they're asleep? My wife sent me a picture when they're asleep. I said, show it to me. Dad didn't think he mouth breathed. Do you think that's mouth breathing? So it's this profile that this boy's function is encouraging to happen. Is this genetic or is it functional? Oh, he grew up and looked just like Dad with his big nose and, you know, he hasn't got a big nose. Underdeveloped midface. So those lips have to be together at night. And if they can't be together, you have to find out why. This one here, my cousin, my nephew's daughter, so whatever relationship that is, Christmas time I said, can I take a picture? Beautiful, little, peaceful, breathing through the nose, lips sealed. Nobody did this, it was just how they were. And look at this one over here. Is this one going to grow up like mum? Okay, and what's this here? Okay, lips apart, falls out of the mouth. And this is another referee friend who's had a baby in the last couple of years. And I explained to him that there has to be solid transition to food. And you have to give food that the baby can pick up and put in their mouth. If they can't pick it up and put it in their mouth, that's not solids. So he sent me this picture of how messy mealtime gets. But then he said this one to us yesterday. The child has eaten. Look at the face now. Okay? They learnt how to swallow. Look at those beautiful cheeks. Look at those lips together. That's going to grow up to be a beautiful girl because the right messaging is being sent. But we have to facilitate the function. So if they cannot nasally breathe because the airway is blocked either through what's going on in the nose or the adenoids or the tonsils or whatever the situation is, we have to get that right. We can't be asking them to do all these things if you can't get a clear airway. Flip side of that is this a nasal disuse thing because they're not using the airway? Not our decision. You refer to the ENT and get their opinion. I don't have to make a decision like that. I just know that's not normal. What if you can't put your tongue to the palate because you've got a tongue tie? You have to deal with that. There's no point teaching them how to put their tongue to the palate if they've got a tongue tie. You have to get it sorted out. They cannot close their lips if their mandible is protruded. You're going to beat yourself up over this, trying to get the kids to, put those lips together, nasally breathe, and the structure has already supported the bad function. So you cannot also correct the posture without correct occlusion to stabilise it. The way the teeth come together is the top of the postural chain. Remember that trigeminal system with all the proprioceptors? Very important message to the body as to where that head is in space. So this is a child, beautiful little boy. Parents are in the body workers have struggled with him for years, trying to get things right for him. And you can see the mouth breathing, he's got a large overjet, and the head posture. And they sort me out, and I'll show you that in a moment. Here, it also is a problem with adults. So this is my future son-in-law when he was still future. This is a dentist who I'm treating. This is post-extraction retraction orthodontics. This is post-extraction retraction orthodontics. Patient is on CPAP at 24 years of age. There has to be an end to extraction retraction orthodontics. I don't care who wants to shoot me down. I'm going to say it, and I'll keep saying it till the cows come home. We are not better than nature. Nature designed us to have all of our teeth, and it designed us to have jaws that are the correct size, shape and position. This is not okay. We have to stop worrying about teeth lining up like little soldiers and worry about the size, shape and position that the jaws are in to actually facilitate them lining up. Taking teeth out does not correct that. It makes it smaller, it doesn't make it bigger. But what if we could do something about it? What if we could guide craniofacial growth and development back to normal at any age? So what if, before we started, we had the class 2 situation? You can see the little teeth coming out on the front. Very hard to get a lip seal when your mandible's back. And through the removable appliance that they wear full time, develop that maxilla forward because it's the one that's wrong, not AP, not lateral I should say, forward. Proper craniofacial growth because our growth centre is at the tuberosity and it marches everything forward. And if all we're trying to do is push bone sideways, that's not how we grow. You have to use tools that actually stimulate growth in the way that nature intends it. And when you do that, you can make changes very significantly in a very short period of time. So this beautiful little boy, it's a priority of care when it comes to children. You can't do everything at the same time. You have to think, well, what have I got to do here? Number one, he needs to be able to get his lips together. He needs to be able to correct his head posture. Okay, he needs to be able to function better. So the first job for me was to move the jaw forward, to give him a bite in not this position, but this one, okay? And what you're going to see is the moment after he stood up from having what I just put in his mouth, which is basically little bridges on his lower primary molar teeth that are bonded to it, at the right bite. And you will see he hasn't had a chance to get used to this. He's just stood up and we've taken the photograph. Okay, now, I facilitate, this moves, guys, it moves. You can put it anywhere, okay? You put it where it belongs, and guess what? He can now put his lips together. Do you think in the more functional world that's going to be a lot easier to get him heading in the right direction now? You try it with that, you can try for years and it's not going to happen. Bring the jaw forward. And on profile, he went from that situation to that. And as the body adapts to that, we keep working with those little, I call them pads, but they're little occlusal build-ups that I've given him to keep correcting it. We can change this. And we're guiding now craniofacial development in the right direction. Another situation here, very similar. That was immediately, well, you can see it's even the same day. We put her little pads in. She's got a lot of work to do yet, but if all I do was try and straighten her teeth out, nothing to do with teeth. That's why I'm not showing you teeth, guys. This isn't a lecture about teeth. It's about understanding the jaw size, shape and position has to be right. That's what I work on. I have zero interest in the business of straight teeth. None. I'll give straight teeth at the end, but that's not what I want to do. My whole interest is developing the jaws to the correct size, shape and position so that we can get them going. So here we have my friend who's a dentist, and that was 10 months treatment. And you can see in that maxilla, it's changed, okay? We have laid down new bone. This was his minimum airway at the start of treatment. He's got quite a wide lateral airway. That is it 10 months later at the minimum. And I'll toggle backwards and forwards, and you can see it's a three-dimensional change that is happening. This is nasal airway. And this is the one I showed you before. This was her airway after, this was the after extraction retraction orthodontics lateral set. So there's still a problem. This is the airway. This is her airway now. And I'm going to show you a little video. We're coming in from the top. Well, that's the airway over there comparatively to the starting point. But you find where that narrow airway is now. Okay? When you develop the jaws to their correct size and shape and position, you're developing the airway. And if you take it away, you're contributing to or worsening a potential sleep disorder breathing problem. It's pretty nice to be able to be doing that for somebody. And my little son-in-law, he is my son-in-law now, they got married. That was a lot of hard work, I can tell you. And I'll finish with this one. These are not my photos, they're his photos. Okay. He is tracking the change that's happening in an adult. So, everyone in this room are the gatekeepers of the airway. Everyone has a critical role to play. We have to observe and recognise. We have to educate and inform. We have to keep learning. We have to be resolute in our purpose and be prepared to stand up for what you believe in. You have to be the inconvenient man. Don't be afraid to have a passion for what you do, because after all, it takes a village. Thank you very much.